giving balanced fluid reduces the frequency of hyperchloremia, but we found no evidence that that translated into a patient-centered benefit.
Welcome back to Peds Crit. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We're excited to be sitting down and discussing the PROMPT BOLUS trial with Dr. Fran Balamuth, Dr. Scott Weiss, and Dr. Nate Kupperman. Will each of you please introduce yourself? Please tell us who you are and what you do.
My name is Fran Balamuth. I am a pediatric emergency medicine physician at the Children's Hospital of Philadelphia. And I am the division chief there of emergency medicine and also co-direct our pediatric sepsis program.
I'm Nate Kupperman. I'm also a trained pediatric emergency physician, but I work at Children's National and serve as the chief academic officer, chair of pediatrics, and the director of our Children's National Research Institute. And I was there at sort of ground zero for the creation of PCARN, this big research network that has led to lots of big randomized trials in pediatric emergency care.
Great. Hi, I'm Scott Weiss. I'm a pediatric intensivist at Nemours Children's Hospital in Delaware. I'm also the division chief of critical care and the vice chair for research for the Department of Pediatrics. And I'm a professor of pediatrics and pathology and genomic medicine at the Sidney Kimmel Medical College at Thomas Jefferson University.
Oh, wonderful. Well, it's great to have you all here, especially our new Children's National leadership, the first author of the study, and Dr. Weiss, who recorded our most popular podcast episode to date. We're here to discuss the PROMPT BOLUS trial. This is a pragmatic clinical trial comparing normal saline to lactated ringer solution in children with suspected septic shock. Just to get started here, this is a huge deal. You enrolled patients at 47 emergency departments in 5 countries. How on earth did you assemble this cohort?
This study, it was a beast of a study that really emanated from the PCARN network, which, as you guys know, has been in existence for 25 years. In fact, we're celebrating our 25th anniversary in a couple of months. Fran and Scott and I had talked about doing this trial, but we knew that PCARN would not be enough. That is, we probably couldn't get enough money from the NIH to do it, and there wouldn't be enough patients in PCARN. But fortunately, we had already developed global collaborations. So PCARN, there's about 5 or 6 PCARN-like networks around the world. There's PCARN, of course, in the United States. In Australia and New Zealand, there's PREDICT. In Canada, there's PERC. And there's networks in Europe and the UK and Spain. So we realized that, hey, let's lean on our global partners. We had already established a global partnership about 15 years ago over the H1N1 pandemic, where we did our first global study. So we wrote the grant for the NIH that would be done in PCARN, but sort of with the understanding that we're going to have to go to other networks and other places to get it done. So, and I want to, big obviously credit Scott and Fran, who really led the grant, and I did my senior author assist. But then we passed it to our colleagues in PREDICT in Australia and New Zealand. They got it funded by their federal government. We passed it to our colleagues in Canada. They got it funded by their federal government. And then Scott and Fran got a separate grant from the state of Pennsylvania. So then when you put it all together, there was now 4 grants, about $10 million, and the potential to enroll about 10,000 patients. And that's really the nidus to do a study like this.
No, that's incredible collaboration. It shows the value of that infrastructure that's already set up, and then just the resourcefulness to add to this to get this study completed. Jumping into the nuts and bolts of the study, what were your inclusion criteria? How did you define suspected septic shock?
So really, I think you guys mentioned this is a pragmatically designed study. So the inclusion criteria were really simple. Enrollment was done by the clinicians in the ED at the bedside, and it was patients if they were worried about septic shock and were planning to treat with at least 2 fluid boluses for the indication of hypotension or poor perfusion. And they were really meant to be simple in that way. We helped people to operationalize that in a way. We gave some guidance around, are you either putting patients on like a sepsis protocol or pathway, because many of our sites had kind of active sepsis quality improvement programs in place. But really, it was what the treating attending physician was concerned about was the main inclusion criteria.
Got it.
And then your primary outcome. Will you tell me what was your primary outcome? And it's interesting that this was perhaps a composite. What is a major adverse kidney event?
Sure. So our primary outcome was MAKE 30, or major adverse kidney events within 30 days, which was censored at hospital discharge for patients who were discharged from the hospital prior to 30 days after the trial. This is a composite of three things. So death from any cause, initiation of renal replacement therapy of any modality, so dialysis, whether continuous or intermittent or peritoneal, or persistent kidney dysfunction, which is defined slightly differently than what we typically think as acute kidney injury. So persistent kidney dysfunction means that you have an elevated creatinine that persists over time and remains at least 2 times higher than your baseline at its last measurement within that 30-day mark or prior to discharge. The reason we like this composite outcome is it includes very important patient-centered components. So death obviously is very important. The need for renal replacement therapy obviously is a burden that families would like to avoid if they can. And then persistent kidney dysfunction is the subset of children and adults who have acute kidney injury that doesn't resolve quickly. And it's that subset of patients that is at higher risk for long-term kidney problems. That's been showed several times in adult studies, and we also, in work preparatory to this study, demonstrated that persistent kidney dysfunction in children who have sepsis is also associated with an increased risk of chronic kidney disease up to 3 years later, also associated with increased healthcare utilization and higher costs. So we really wanted to understand kind of whether or not the use of balanced fluids will reduce lasting impacts on the health of these children, rather than whether it just simply contributed to a transient acute kidney injury that may be less meaningful long term.
Oh, absolutely. So validated as a patient-centered outcome, both in multiple adult studies and then in the pediatric population with your prior work. And this, I mean, I'm sure why you did the study, why it was funded by so many institutions or nations is there's a pretty strong precedent for lactated ringers or balanced solutions over normal saline in the adult population, right?
Well, so that's an interesting question, Alice. There are now several studies in adults that were really precipitated by earlier studies that were either observational or even preclinical studies. So it's very clear that there's an effect of hyperchloremia on kidney perfusion. Certainly, delivering an excessive amount of chloride to the kidneys affects the way that blood flow is regulated through the kidneys by changing blood flow in the afferent and efferent arterioles and the juxtaglomerular apparatus and so on. So it's very clear that chloride is important to renal blood flow, and high chloride generally decreases renal blood flow, and at extreme levels that can cause harm and ischemia to the kidney. And there is an association between elevated chloride levels and worse outcomes in both adults and children in sepsis and in other conditions. So then the natural question was that if you try to prevent such hyperchloremia with a lower chloride containing crystalloid solution, such as lactated ringers or Plasmolite or Hartmann solution, Normasol, and so on, could you improve patient outcomes? Now, there were 2 big trials done at a single center in the United States at Vanderbilt that demonstrated improvement with balanced fluids. Unfortunately, those results have not been consistently replicated in some of the other large adult randomized trials, such as PLUS in Australia and New Zealand and BASICS in South America, as well as a big multi-center crossover trial that was recently published in Canada. And meta-analyses of these studies have not demonstrated a clear significant benefit of balanced fluids. So it's a little bit mixed in terms of the evidence. So our results, which did not find a benefit of using balanced fluid, at least in terms of MAKE30 and other secondary patient outcomes, are not inconsistent with the totality of the adult literature, although there's a little more variability just in the 5 or 6 studies that have been done in adults.
Alice and Zach, if I could just add one thing to actually a previous question, but pertain to what Scott just said around our outcome measure. It's not that all of the adult trials have had mortality as their outcome, but many have, because in adult trials, adults die, and in the pediatric literature, when we looked at the power of this, even after doing what we said, amassing 9,000 children through 3 global networks, et cetera, we realized we still would not have the power to show a clinically meaningful difference in mortality. That's why we had to go with MAKE30. And that's also one of the differences between the adult trials. Again, some of the adult trials have looked at similar outcome measures, but many of them have gone after death as the primary outcome. We knew that we were not going to be able to do that.
Oh, yeah. Yeah, can't compare mortality rates in adult ICU populations like the Vanderbilt study, I'm sure.
Right.
I want to ask about your power calculation. It looks like your power calculation was based on a study that Fran and Scott did on the Pediatric Health Information Systems database that looked at children with an ICD code or with a diagnosis of severe sepsis or septic shock. And they saw a 6% event rate, or you expected a 6% event rate based on that study in at least the normal saline group. In your study results, you got about a 3.4% event rate in both groups. As clinical trialists, how do you reconcile this, that it's lower than you expected?
Yeah, it's a great question. I mean, I think you guys can all chime in on this. I think, we struggled a lot with kind of what source data to use for our power calculation. And so we had a few options. One were kind of epidemiologic studies, either done by us or by others, that use sepsis ICD codes, which, as you know, is number one, ICD codes are imperfect in identifying sepsis, even in an ICU population. But kind of the power of ICD codes aside, those are patients with confirmed sepsis. And we often don't know when patients walk in the door, are they going to end up with a sepsis ICD code or not? If we resuscitate them well, they may go on to do well, right? And not end up in the ICU and not need all of the critical care. And so we were kind of trying to incorporate knowledge from epidemiologic studies with ICD code-based sepsis work. We did have some institutional databases around quality improvement and research in suspected sepsis populations, both at our hospital in Philadelphia and then a partner hospital in Children's Hospital of Colorado. And so we did use epidemiologic estimates at those two sites to also feed our power calculations. And then the third source was the Vanderbilt trials that Scott mentioned. And so that was obviously an adult study, and they enrolled patients 18 and above. But we did look at MAKE-30 rates in the youngest patients in the Vanderbilt trial. So we looked at the patients 18 to 21 years of age and kind of used a combination of those three sources. So kind of individual databases at two sites, plus the ICD code-based studies, plus the Vanderbilt studies to kind of come up with an estimate that we thought would be reasonable in the suspected sepsis population. The fact that it did turn out lower than expected, I think, is interesting. And I think we still don't completely understand exactly why rates were less, right? Like, it could be possible that sepsis outcomes have improved over that time period. It could be possible that we, enrolled a broader population than was accounted for in those studies. I think that's probably the most likely reason, but you guys can comment as well.
Yeah, if I could just add something, then Scott, I'll pass it to you. If you look at the positive blood culture rate, and even that event rate for a setting like the ED, where remember our population, as Fran said, was not proven sepsis, was suspected sepsis in the ED setting. So that by definition kind of sets a little bit of what we knew were going to be a little bit lower event rates. Nevertheless, our positive blood culture rate, although at the low end, it's consistent with other studies that have been done, but again, very different than a study that would have been conducted purely in the ICU.
Oh, absolutely. Now, let's get to your results. How many patients about were you able to enroll in each group?
So we enrolled a total of 9,041 patients, 4,512 in the balance group and 4,529 in the saline group.
And then as a follow-up on that, do you feel like they were equal in respect to their morbidity related to your primary outcome? And then do you feel like this population was representative of the global population of children with septic shock, and maybe thinking about high resource versus low resource settings?
Yeah, so all super important questions. So I guess to your first question, I do think that, number one, the randomization worked well. The groups were incredibly well balanced. Kind of everything that we looked at in our table one, both across kind of demographics, across country, across underlying comorbid conditions, we saw no differences between the groups. I think in terms of generalizability outside of the high resource settings, so all of the settings where patients were enrolled were high resource. So we can't technically make comments around low resource settings, but I guess the reason we designed the study to be pragmatic is we hope that it would be kind of easily translatable to lower resource settings, in that these fluids are universally available, really cheap, require no special storage conditions. And the pragmatic way that we enrolled them, kind of with the clinicians driving the bus at the bedside, hopefully will make it such that translation to the bedside is simple.
And, I'll add, as this study was conducted really in PCARM, but really this global network is called PERN, the very complicated acronym, Pediatric Emergency Research Network. That's what PERN stands for, this consortium. But we had kind of a globalist mentality at the outset, knowing that first, low-cost intervention, available to everybody. And we thought that by itself makes it also highly pertinent to this global network.
Yeah, just one other thing to add around kind of the degree of illness of patients. Like I do think there is face validity in that the proportion of patients, 14% on vasoactives, 10% with invasive mechanical ventilation does track with other sepsis epidemiologic studies published on this suspected sepsis population. So I do think that it has face validity, at least in other studies in this space.
Oh, that's excellent. Scott has already suggested this, but will you review for us the key primary and secondary outcomes of the study? And then maybe what does this mean for the treating clinician who's taking care of that next child with septic shock in the emergency department or the ICU?
Yeah, I'm happy to jump in on that one. So the primary outcome of MAKE-30, we saw 3.4% of the children randomized to balanced fluid and 3.0% of those randomized to saline met criteria for MAKE-30. And that had an effect measure overall after accounting for randomization by site of 1.10 with a 95% confidence interval that crossed 1. And so with a p-value of 0.85. So that was not significantly different. Now, you don't want to put a whole lot of stock into trends, but the point estimate was really and actually on the side of favoring saline. But again, that's a little bit dangerous to start parsing the data in that matter. So the overall primary outcome was not significantly different. Importantly, we also did not see differences within each of the 3 composite endpoints of death, new renal replacement therapy, or persistent kidney dysfunction. They were also equally balanced, and each of those was also on its own had an effect measure that was included 1 in the 95% confidence interval. That's really important because there could be actually some trade-offs, right? So perhaps you got more kidney dysfunction, but less death. And so, there could be some trade-offs. And that's one of the challenges with using a composite endpoint is that not all of the components might be equally valued by patients, but we did not see any differences within the components. We also did not see differences in death prior to hospital discharge, death within 90 days, or any differences in overall length of stay or number of days free from being alive and free from hospitalization during 28 days. So none of the efficacy endpoints differed between groups. We also looked at some safety outcomes. So cerebral edema is an important one to consider because lactated ringers was used as the balanced fluid in about 80% of all times that clinicians chose or went to balanced fluids, they chose LR. And so there was a slightly hypotonic solution compared to, say, saline or plasmolite. And so there's a possibility of increasing cerebral edema. We did not see a signal of harm there. And in fact, that occurred in less than 0.5% of patients in both groups. There's also a concern about the calcium component to LR and that increasing the risk of thrombosis, particularly with co-administration of ceftriaxone, which is the most commonly administered antibiotic for these patients. And again, that occurred at a low frequency and in a similar manner of 1% in both groups. Now, we looked at electrolyte differences as well. And here we did see differences that were expected. So, for example, in the saline group, we saw much higher rate and significantly higher rate statistically of hyperchloremia, which was somewhat reassuring to us to know that the intervention worked, right? Patients who were randomized to saline were expected to have more hyperchloremia, and in fact, they did. So in some ways, that was reassuring. Notably, however, the children who received balanced fluid also had a fairly high rate of hyperchloremia of 30%. So hyperchloremia is common in sepsis, irrespective of the fluid. So there's more to the physiology of these biochemical differences than simply the crystalloid fluid that they're being administered. And there's certainly a discussion about vasopressin deficiency and so on in there. But the most important sort of way to interpret all of these data, right, is that giving balanced fluid reduces the frequency of hyperchloremia, but we found no evidence that that translated into a patient-centered benefit. So you can choose to give balanced fluids to reduce hyperchloremia and the associated metabolic acidosis if you want, and if that's annoying, and there may be reasons to do that, less lab draws, less other downstream problems, and so on. So there could be reasons to do that, but that didn't definitively translate into patient-centered benefit in our study, which I think is a really important finding, because to this point, people have often made the leap that if you reduce hyperchloremia, you will improve patient outcomes, and PROMPT BOLUS did not confirm that.
Can I add, Alice and Zach, sorry to switch topics, but I'm going to DKA, which I know you've podcast my wife, Nicole Glazer, on that. But as you recall, we had a large randomized trial also published in the New England Journal in 2018, in which we compared half normal versus normal saline. And indeed, the normal saline arm, there was a lot more hyperchloremic and metabolic acidosis. Just as here, didn't translate to any patient-centered outcomes and did not even translate to longer stays in the hospital. I know, of course, a different medical condition, but with similar findings to what Scott just described.
Oh, absolutely. And I was also thinking about DKA when you brought up hyperchloremia, because you know we hate to keep that insulin drip going when they're hyperchloremic, but that's
Right, exactly.
But I digress. Yes, thank you. So really, the battle of the fluids continues. The three of you are, at least division leadership or above at your respective institutions, and you've got strong ER sepsis bundles, I'm sure. I'm wondering if the fact that maybe it doesn't matter as much as we thought it did at the population level, is it informing your individual practice? It is informing the way you talk about the sepsis bundle at your institution, and why or why not?
Yeah, great question. So I guess before PROMPT BOLUS was published, we always had kind of both Belar and saline as options in the sepsis order set, and there was not kind of clinical decision support pointing you in one way or the other. And then during the 5 years of the study, we obviously were randomizing all of the patients, and so we had no clinical decision support there either. I think really my interpretation of this is kind of, if I was going to go work in the ED tonight, is to treat the patient in front of me, right? Like both fluids are safe, both fluids work. And really for that initial resuscitation, upwards at whatever I'm going to give during the patient's time in the ED, I can give whichever one I want. And there may be individual patient characteristics, that would make me give one or the other. If I was concerned about cerebral edema, specifically a safety concern or something, I may choose one or the other. But I think for the vast majority of patients, especially for the first 60 per kilo, you can confidently give whichever fluid you want.
I'll add on the ICU perspective. If there's a fluid available and hanging and the child is hypovolemic and needs fluid, then either fluid is fine, and I wouldn't spike a new bag if one was available, and I think that's totally fine. We have chosen here, at least, to continue to prioritize giving balanced fluids for patients who continue to need ongoing fluid resuscitation in the ICU, because why not? It works as well as saline, and if we can avoid some of the biochemical annoyances, which can create some confusion, then that's maybe a small benefit. And we have the luxury of having both fluids available. They're not major cost differences, and generally we're working with patients where there aren't issues with compatibility. We usually have more than one IV in these patients. And so we have those luxuries. And so, if you have a choice that gives you fewer biochemical problems and normal labs, that could have some downstream tangential benefits, fewer lab draws and so on, and less confusion around interpreting other biochemical differences, like is this metabolic acidosis driven by hyperlactatemia? Is it driven by a non-GAP acidosis, right? So I think there's some potential benefits. But we're much softer on that now than we were before. We're not preaching the need for balanced fluid. It's just a choice that has some tangential benefits. But for other units where there's a cost differential or there's a lack of availability, then you should feel comfortable being able to restore the volume loss and the volume depletion with either crystalloid fluid and know that it's safe to do so.
And if I can add that, remember in this trial, we studied patients from the time of enrollment till midnight of the following night, right? So in that time window, in our ED sepsis bundle, no change, because in the ED setting, we are practicing well in that window, right, until midnight of the following night. One thing that a lot of folks have asked us, well, what do you do for the patient with ongoing sepsis who's having, at that point, this study did not study what fluid to give at hour 56 or 60. And that, of course, is a clinician discretion choice. And again, that's why I think there's differences in potential changes in ICU bundles that's in Scott's setting versus in Fran's and my setting in the ED, where there's less need to direct care as to which fluid to choose. I will just add one of the beautiful things, again, because I do a lot of work around the globe, there are certain settings that they only have one or the other fluid. And the beautiful thing is whichever one is fine. So that's sort of some other thoughts about that.
No, I really appreciate each of your comments. The pragmaticness of give top fluid if they need fluid, if they're in hypovolemic shock, especially in the emergency setting when they're getting acutely resuscitated. And I also really appreciate, Scott, your comments about just how annoying an additional layer of acidosis can be for our complex patients who are accruing multi-organ dysfunction in the ICU. And there just seems to be some kind of just mental relief about not contributing to the ongoing pathology in front of us there. I wanted to talk more about just how we situate this study and our broader clinical recommendations for how we take care of kids with septic shock. Of course, this paper was published in the New England Journal of Medicine on April 24th, 2026. 1 month prior, the 2026 Pediatric Surviving Sepsis Guidelines were published. And in that guideline, it was suggested to use balanced crystalloids over saline, but a very low certainty of evidence. And the irony here is both Scott and Fran were on those guidelines. I was wondering, were the results of this trial available when writing the guideline? And I guess yes or no. And then how do you feel like these results may or may not inform that recommendation to be different or not?
I'll let Scott take that one since he's the leader of both.
Yeah, it's a great question. It's a tricky thing. The timing of things don't always work out exactly how you want them, right? And, the guideline development through the Surviving Sepsis campaign is a highly rigorous, evidence-driven process, right? It's really meant purposely to exclude preferences and opinions and really follow the data and the evidence, right? Which, fortunately, is why so many of the guidelines aren't strong, weak recommendations, right? Because we just don't have the evidence to support that. So it takes a long time, as you can imagine, to comb through the literature, bring the dozens of experts together, discuss the evidence, review it, and so on in a rigorous manner, and then develop the document and then have it go through peer review and so on. So the guidelines were written and sealed before the trial even finished enrollment. And so, unfortunately, the data from PROMPT was not able to inform those guidelines. And it wouldn't have been fair or appropriate to do a last-minute change to that process. Those guidelines are date and time stamped, just like all other articles. And so people need to be able to review and understand those guidelines in the context of continually new evidence and data. And this just happens to be on that balanced fluid recommendation, but there's other examples as well. Really, we need to be doing is moving our guidelines more to kind of a living document approach, right? Where they're sort of constantly being updated as new evidence becomes available instead of every 5 years, right? Just, on some somewhat arbitrary clock. So there is a plan for the Surviving Sepsis to move towards that model. And so things like new trials coming out can be instantly added into and the evidence synthesis can be updated such that if they do change the prior recommendation, in this case, I believe that it probably would, then that can be incorporated. But for now, we're not quite there yet, unfortunately.
Oh, wow. Well, that sounds like the future of medicine, to be updating it in real time. Would that just be like a quarterly meeting situation where the writing group sort of always is meeting instead of meeting once every 5 years?
Correct, right? It would be a continual review process, right? Mm-hmm. Instead of just a staccato kind of predetermined timeline. Exactly.
Now, I also want to ask about, you guys were enrolling patients from 2020 to 2025. In 2024, at SCCM, they released the Phoenix Sepsis Criteria, which is a computable phenotype designed to identify patients with sepsis retroactively, is the way that I think about it. Do you have sufficient data in your cohort to kind of apply Phoenix sepsis in a secondary analysis, or no, because that would be crazy to collect?
It's a great question. We unfortunately do not have all of the nuanced detail. We kind of made the data collection for this in meeting with the pragmatic goals of the trial and honestly limited by the funding capability that we had and the ability to deep dive the medical record across this many children at this many sites. We kept the data collection pragmatic and pretty minimal to what we needed to answer the specific questions that we set out to answer. So I wish we were able to look specifically at Phoenix. We are not going to be able to do that with the primary data set. That said, we do have an ancillary study that's being led by Julie Fitzgerald, where we have been able to link some of the trial participants at PedsNet sites to PedsNet data, and we're planning to follow kind of longer-term kidney outcomes in those patients as the primary aim of that study. But because those studies are kind of linked to the electronic health record, I think there is possibility that we could look at a subset of patients with Phoenix potentially using that as a mechanism.
Oh, well, that's very exciting. And of course, you have a plan to continue following these kids.
Yeah, I think a related question, Alice, right, which your question just kind of danced around a little bit, right, is as an intensivist, the easy criticism, right, is, oh, these patients generally weren't as sick as the patients I take care of in the ICU, right? Like, so for my patients in the ICU, right, the subset of these patients who came to the ED, many of whom did not need the intensive care unit, or if they did, they got better quickly. But the subset that were really sick, those are the ones where balanced fluids must matter, right? And so we were upfront in the limitations to say that, we didn't have the numbers to look at all subsets, including that fraction of, perhaps the sickest of the sick. But our other stratified analyses looking at subsets did not demonstrate a signal towards benefit. There was no heterogeneity or treatment effect, depending on whether or not you came in with a more severe acidosis or an elevated lactate. whether or not you presented with stage 3 acute kidney injury by KDIGO criteria, right? We did not see a signal. Now, in the supplement, we presented some data looking at the incidence of MAKE30, depending on the volume of fluid the patients received. And there were a handful of patients, a few hundred, who received extremely high fluid volumes, more than 150 or 200 mLs per kilo in that 48-hour time window that Nate mentioned earlier. And in those patients, there was a trend towards lower MAKE30, although not statistically significant. But notably, it's just such a small number, right? And I think that reflects the fact that we've changed the way we've managed sepsis, right? We're not inundating patients with fluid in the same way that we were 5-10 years ago, noting the concerns about the potential detrimental effects of fluid overload. So even our sickest patients are not getting enormous amounts of fluid in the same way they were when I was training. And I think that's good. Now, at extremes, if you are, or a patient does require that amount of fluid, maybe there are benefits, right? Because you're operating at an extreme where toxicities may not matter for the majority, but in an extreme case, maybe there could be. And we can't exclude that. But for the overwhelming majority of patients who need a moderate amount of fluid resuscitation, regardless of the level of illness severity, there does not seem to be a protective benefit of balanced fluids here.
Oh, well, that's very good to hear. And to Fran's point, a lot of these kids didn't need the PICU. You're welcome, so.
We appreciate you down there.
Okay, so now you're still doing follow-up trials. You're going to pair these data with other data. You also have this database of about 8,500 patients with suspected septic shock that's international. This is kind of like the RESTORE trial where I'm like, even this year, finding new interesting secondary analyses that inform like completely different questions. I'm sure you have a rigorous process for within your study group who can use those data and how you're planning on. Is there anything specific that we should be looking out for or excited about?
Hey, Fran and Scott, maybe you should first talk about you mentioned Julie's secondary analysis, but the ancillary R01s, the other ancillary R01, before we talk about the database, there's another ancillary R01.
Sure, yeah. So I think the two additional things that are going to come out are biomarker based. So Nate mentioned in the beginning that one of the grants we had gotten was from the state of Pennsylvania. And this was to kind of do a nested trial within the trial looking at kidney injury biomarkers and a subset of patients that were enrolled in the state of Pennsylvania. So that will be coming soon, looking primarily at NGAL, but other kidney biomarkers as well. We have a series of 5 kidney biomarkers that we're going to look at. And then Nader Yehia, who is another intensivist at the Children's Hospital of Philadelphia, is also doing a study looking at endothelial injury. So we have some blood-based biomarkers as well that were collected at 3 of our sites. So those are coming out. And then we do have also some planned secondary analyses of the clinical data as well, looking at particular patient subsets. And I don't know, Scott, if you want to add any more details about that.
Yeah, I'll just say, so Nader's ancillary is not only looking at endothelial dysfunction and whether or not that was precipitated by one fluid or the other in different ways, but he's also looking at a stratified analysis based on Hector Wong's Persevere risk stratification system. So we have low, middle, and high risk of mortality based on Persevere. So that will be part of that analysis as well. So that'll add another marker of illness severity that's been validated. So that's coming as well.
And let me just add, as part of the PCARN process, any big randomized trial, big observational study of PCARN typically produce 10 to 20 manuscripts. But we're not trying to slice the salami thin. As you were suggesting, Alice, there is really a lot of meaty information in here. And the typical process will, we have a lot of examples of that, but typically we will lead the writing on several, but there's a lot of site investigators who get a lot of options to write. And I don't want to guess, but I would say probably from this data set, maybe 10 or 20 manuscripts over the coming few years, something in that ballpark, outside of these ancillary studies that Scott and Fran just mentioned.
Oh, well, that's very exciting. And also that you got biomarkers. Yeah. We look forward to reading that.
I do want to say one of the, there was a number of things to me as a global clinical trialists that were so important. First of all, sepsis, as you know, one of the leading killers of children globally. So that was really important. The way that we were able to just pull this off and bring international colleagues together, I will just give a shout out for international collaborations. It's a small globe and we need to work together to make things work. And then we purposely did this very pragmatically so that although we didn't get all the information that ideally you really want, we got the key information and we did get biomarkers in that subsequent grant. And that's, really fundamental. But we were able to pull this off with usually, just so your listeners are aware, when we would randomize children in the ED, There was no team that came down to help me randomize. We would just do it because it was such a pragmatically designed trial. You could really do it by yourself as the clinician. Typically in PCARN and other big studies, a team will have to come down to help with the consent and the enrollment, et cetera. This had, the federal waiver from informed consent, and the clinician alone could enroll. So lots of things that just came together to make this a great and important and impactful study.
No, that's excellent. As we're coming to the end of the conversation, I wanted to say congratulations to each of you for the hard work. Congratulations to the site members who led their respective divisions. And I think also just thanks and congratulations to the pediatric emergency medicine, pediatric critical care, pediatric hospital medicine communities for working together collaboratively to get this study done. Balanced fluids versus saline. It's always been quite a passionate discussion. And sometimes these areas of controversy, sometimes the data is just not clear, and that's driving those robust discussions.
Thanks for that. Just to underscore one more time, just kind of the joy that came from building this team. The ability to work collaboratively was necessary for the study, but I think also was heartwarming in a way, I guess, to build, I think the ED and the PICU, we work together every day to take care of patients who walk through the doors. And, sometimes we argue about things and sometimes we come together in the scariest of moments. And I think the ability to kind of build research infrastructure and academic collaboration in this space is something that we really, I think both Scott and I and Nate all hope that this kind of extends into the future and allows us to answer the next questions as well.
This, I think, really does send a message to clinicians, researchers, collaborators in this country, around the globe, that working together makes the magic happen with different lenses, and not only the different lenses of the ICU and the ED, but the different lenses that come from collaborating with our global partners. I think the message is really clear about how the magic happens.
Oh, well, that's wonderful. Drs. Balamuth, Weiss, and Kupperman, thank you so much for joining us today.
Pleasure. It was great to be here.
Thanks so much.
Thank you very much.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.